Good afternoon, everyone. I welcome you all for the inaugural function of the 5th Annual Conference of Mumbai Surgical Society, MSSCON 2023. Dr. Kamal, I request you to please escort our chief guest, President ASI, Dr. Sanjay Kumar Jain, to the dais, please. Honorary Secretary, Dr. Shishi Shetty, to escort the orator, our guest of honor, to the dais. Start from this side. Dr. Rajesh Yadav, Vice President, to escort the Dean, Dr. Mohite, our guest of honor. I again request Dr. Shishi Shetty to escort Dr. Sanjay Kolte, President Masi, to the dais. Dr. Rajesh Yadav, please escort Dr. Utture, Vice President of IMA National. Dr. Shishi Shetty, to please escort Dr. Ravindra Kunte, President IMA, Maharashtra. Now I invite, sir, please take your seat. Now I invite Dr. Shishi Shetty, Honorary Secretary of Mumbai Surgical Society, to begin the proceedings.
Good afternoon, everybody. Welcome. It's a great honor and privilege to be at Cooper Hospital, where I trained many years back. Very beautiful auditorium that you have here. Thank you for the arrangements. Dr. Manmohan Kamath and the team were very nice enough to allow us to use this hall for the MSS program. This is the 9th AGM since our repeated. The last AGM was held on the 20th of March at Shri S.P. Jain Auditorium, Bombay Hospital. Before we start the session, we would request everybody to stand up for a moment of silence to offer condolences to Dr. P. Purwadian and Dr. Ratnakar Shetty. Thank you. Please sit down. I would like to present my secretarial report in brief. Tell you about the activities which was done last year. So the conferences which we did was on the 4th, last year in the same time, March, we did the annual conference in Bombay Hospital. There were virtual lecture series which started from 23rd April 2021. We completed 38 series covering important topics in surgery. The teaching program in the form of webinars, lectures on important topics by prominent speakers series were conducted every Friday night diligently. There is a YouTube channel which has been started, which has all the video recordings of the lecture series and more. They are uploaded for everyone to see. Virtual video series showing different surgeries was inaugurated on the 15th of April by Dr. Siddesh, President of ASI. And so far, 20 such series have been conducted so far, covering topics of interest in general surgery for everyone, including PG students by recognized teachers. Virtual PG clinics were started from 24th of April 2022, and 10 such series have been conducted. So far, lectures have been taken to cover most of the important topics for postgraduate exams. Today's presentations, question and answers, everything had been covered. An oncology update was held in Nanavati in April. Workshops was organized by the hepatobiliary unit at Cooper Hospital. The Department of Surgery conducted a laser in surgery and answer update. Workshop in CME on 19 June at Nanavati, again for hernia update. Masterclass in groin hernias masterclass was done on 6th of August at Cooper Hospital. A webinar was done at Nair Hospital, which conducted a live workshop which was relayed from the Nair OT. All about hernias at CME again on 29th October from Faces East Club at Jaipur in collaboration with Zen Hospital. Social awareness program was conducted on the 5th of November at Kurla Baba Hospital during the World Diabetic Week by Dr. Ruke. A cadaver workshop was done at MGM Hospital, Kalamboli. It was a live VATS hands-on cadaver experience. A social awareness program was conducted by Dr. Manmohan Kamath and Dr. Machu for senior citizens on common surgical emergencies arriving at home. A workshop on GI was held at Sion Hospital on the 21st of Jan by Department of Surgical Gastroenterology and MSS. The most important thing which was done by the MSS was the 82nd annual conference of ASI, which was held in Mumbai, was organized by MSS and MASI by Dr. Parvesh Sheikh and Dr. Niranjan Agarwal from 21st to 24th of December. The live workshop was attended by 1,500 delegates and a conference of more than 6,500 delegates. 6 MNC credit hours were given, and it's been a great year for MSS. So I hope 3 cheers for MSS. With small request that every member of Mumbai Surgical Society who started with a small organization hold such a big thing that they should endeavor to make one more member so that eventually it becomes a big group.
Thank you, Shishir. I request Dr. Manmohan Kamath to felicitate our chief guest, President ASI, Dr. Sanjay Kumar Jain. Thank you, sir. I request you to felicitate President MASI, Dr. Sanjay Kolte. Thank you, sir. I request you to felicitate Dr. Utture. Shivkumar Utture is Vice President National IMA. Thank you, sir. Now I request you to felicitate the President of IMA, Dr. Ravindra Kutte, Maharashtra State. Thank you, sir. I now request you to felicitate our Dean of Cooper Hospital, ITMC, Medical College, Dr. Mohite. Thank you, sir. Friends, amongst us is our beloved past president of ASI, Dr. Abhay Dalvi. I request Dr. Manmohan Kamath to welcome his and recognize his presence by a floral bouquet. He was also the patron of the MSSCON 2022 that was recently conducted. Without whose guidance and patronage, Mumbai Surgical Society would not be there where we are right now. Thank you very much. Now I request all the dignitaries who are there on the dais to please come and light the traditional lamp of knowledge, including Dr. Dalvi.
It's okay.
Thank you, sirs. Please take your seats. Dr. Manmohan Kamath, President, MSS, will address everyone.
Good afternoon. Respected Chief Guest for today, President ASI, Dr. Sanjay Jain sir. Guest of honor, Dr. Shailesh Mohite sir, Dean, HBDMC Cooper Hospital. President of ASI, Dr. Sanjay Kolte sir. Vice President IMA National, Dr. Shivkumar Utture sir. IMA Maharashtra State, Dr. Ravindra Kutte sir. Past President of ASI, Dr. Abhay Dalvi sir. And our founder President of MSS, Dr. Kishore Adhyaya sir. All my respected teachers and friends from the family of Mumbai Surgical Society. It is indeed a privileged moment for me to address you as the President of Mumbai Surgical Society in this gathering of 5th Annual Conference of MSSCON 2023. We are indeed privileged to have so many stars, not only from the city, state, but from the country for this Congress today. A year back, when I had taken over as the President of MSS, I was a bit skeptical regarding whether I could carry out the responsibility of this esteemed organization due to my health issues. However, due to immense support of our office bearers, EC members, and all the members of MSS, I could successfully carry out activities of MSS in the previous year. COVID era has taught us the technique of online learning. During this year, our combination of online as well as offline academic activities got us the Best City Chapter Award in academics this year. Online PG clinics were very popular in the postgraduate students and received a very good response throughout the year. Virtual video series was a new but a regular feature for Friday night. The presenters were from the very senior to very young, talented members of Mumbai Surgical Society. And the first, as you just heard, that the first virtual video series chaired by none other than Dr. Sitesh, who was then the president, and the last, that was 20th, was this month, was chaired by Dr. Sanjay Jain. And though he was traveling, he was gracious enough to chair that session, online. Thank you, sir. The most of these recorded videos are available on our MSS and as well as Masi's YouTube channel. For the first time this year, we had 4 live workshops conducted by MSS, which hardly any other surgical society has done so far. Though the MSS city chapter of ASI is a very young city chapter, the performance of height MSS has achieved in such a small time frame is indeed remarkable. In such a small span of time, we have successfully conducted not only the state conference, MSSCON, but also the MSSCON 2022, which is considered as the tomb of the surgical conferences. And this was under the able leadership of our own members, Dr. Parvez Sheikh and Dr. Niranjan Agarwal. Encouraging students, UG, PG, should always be the aim of any surgical or medical society. Keeping that in mind, we have arranged many courses such as the basic surgical skill workshop, laparoscopic surgical skill workshop, stapling and bowel anastomosis workshop, upper GI endoscopy workshop for the first time in our annual conference. This will certainly help students as well as create a good image of our surgical society and make a positive impact in their young minds. Throughout this year, besides the support of MSS members, I must express my highest gratitude to the surgical departments of Nanavati Max Super Speciality Hospital and HBTMC Cooper Hospital. All the members from these departments have unconditionally supported me during the entire year. Friends, my association with Cooper Hospital goes back in time as long as 1992 when I first stepped in as an assistant professor in surgery from GS Medical College posted at Cooper Hospital. The journey of 30 years, barring few years in between, has seen a lot of changes from infrastructure to an independent medical college. This is my last year, or rather the last month at Cooper Hospital as an honorary surgeon. This place has taught me not only surgery but gave me excellent teachers and very good students who are my colleagues today and are doing extremely well in the surgical fields. I can see many of them in the audience today who have specially come today to visit the allotment. My sincere thanks to all of them. Our Dean, Dr. Shailesh Moite, is a very dynamic administrator who is extremely passionate regarding the academic activities. Friends, Cooper Hospital soon will be setting up a cadaveric lab, which is a dream project of our Dean Sir, and which will help surgeons to master their skills. With such a good leader and enthusiastic, talented, energetic team of the surgical teachers, the Department of General Surgery at Cooper Hospital is going to be one of the best departments. Finally, I thank my secretary, Mr. Santosh Gowde, who did all that artwork for the online teaching program, which otherwise would require some professional agency to be hired. I thank Dr. Arbaz Momin, Dr. Bharat Kama, Dr. Priyanka Bhaktani, and Dr. Vishal who has worked relentlessly for the happening of this particular conference. Dr. Naresh has been a backbone of MSS and is always supported and always guided us throughout our all activities in this regards. I think all the industry will support it for this particular event. I can say with pride that if all the academic activities of MSS members are combined together, which they are doing at individual capacity today, it will be more than any city chapter in the entire country. Such is the potential of our Mumbai Surgical Society. Long live MSS, long live ASI. Thank you.
Thank you, President Sir. Now it's indeed an honor for all of us that our chief guest is none other than the President of ASI, Dr. Sanjay Kumar Jain, who has been a great support all through during the MSSCON preparation and even now as we conclude and bask in its glory. On behalf of Mumbai Surgical Society, I invite Sir now to deliver the chief guest address. Dr. Sanjay Kumar Jain.
Good afternoon, everybody. At the outset, I would like to thank the Mumbai Surgical Society for inviting me, probably this is the second visit in the same month to this great city of Mumbai. And just before I start, what I would like to say about the Mumbai Surgical Society, this is probably the youngest society with the most experienced member and that is the reason for success of this society. So, guest of honor for the day, Dr. Shailesh Mohite, sir, who is the dean of this very college, Dr. Abhay Dalvi, sir, Dr. Kishore, who is the founder president, Dr. Sanjay Kulte. We have two of the dignitaries who are, I will be looking at them for some guidance, Dr. Shiv Kumar Uttare, who is the vice president of IMA National, and Dr. Kulte, who is the president of the Maharashtra IMA. We have the officials of the Mumbai Surgical Society, Dr. Kamath, Dr. Rajesh Yadav, Dr. Shishir Shetty, Dr. Naresh, and all my friends here, and the most encouraging that I see a lot of young friends here. See, this is probably an academic event and not to talk much. I will be focusing on 2-3 very important and pertinent points. One, for the young colleagues, I will start with them. They have to make their career, and you are most fortunate to have the teachers like them, the surgeons to mentor you, to take advantage, number one. And also, the ASI is there to support you for your dreams. As we are having programs which are running throughout the years, the academic programs, especially catering to the needs of the young postgraduates and the surgeons. And these are like, we are running online National Skill Enhancement Program. After this, we will be coming up. What it was started in Dalvi sir's time was the membrane quiz, and I promise you that you all are going to enjoy this quiz. And following this, which has been very prestigious, that is the ASI Torrent Young Surgeon Award. So these regional refresher courses will be on the offline platform, and you will get the versatile opportunities. The Mumbai boys have always done, and they have stood in top of the row. Here, what I would like to say, that this year we have made, it has been promised for a lot of years, but it has been made real. Like the first 3 toppers, they are going to Japan Surgical Society meeting on their invitation. The next are going to Malaysia, US, and Sri Lanka. So all those who are 12 selected, so what I would like to say, avail this opportunity, get selected. It is just for your support we are doing. The prizes in the membrane we have increased to 18. There are 2 categories. One category for the postgraduates and one category for the senior surgeons, because you cannot compare the apple with the oranges. So I have kept them apart, and it is again Dalvi sir's suggestion. Sir, there are 18 prizes in each category. Actually, what happens if there are only 1 or 2 prizes? We ourselves get disheartened that what we will do, we are not going to secure in the Lord. So there are a lot of opportunities, and this is not that throwing away the prizes, it is just encouragement. Giving 2,000, 5,000 rupees to anybody does not make, but the certificate which you get, satisfaction you get, which is most important. So please participate in all these events, make them successful, get the advantage of it, and let us get what Shishir said, that make more members, make our association strong. This is very, very important. And why I especially mentioned about the IMA. IMA is the biggest body in this country. And sir, Dr. Uttare is with me. And we as a surgeon are the biggest body in the Asia Pacific, and we have already started working together. And here we are seeing there are a lot of atrocities, lot of problems happening with the doctors because we are surgeons or gynecologists or ophthalmologists after being a doctor. So IMA we look at as the big brother, and it will be good only if we join hands and work together and take these problems together. Then only we will succeed. Otherwise, if we fight as small associations, it is not going to make any impact. So this is something, sir, I would like to take your opinion and advice, and we are keen to be helpful to whether the surgeons or the doctors wherever in the country. The things have gone wrong in Rajasthan, things have gone wrong in Kerala also, and everywhere, every now and then things are happening. So we all are together, and the issue of this Ayurvedic surgeons also, I was keeping quiet for some time because it is very important to get the iron in this pot. And I have some thoughts on this issue, which again I want to discuss with you. I think telling more than this will not be appropriate here. I hope, and was only one thing which I would like to tell to conclude my this thing is very, very important. I was made to understand that Mumbai is a city, it's very professional, it is very business, but my experiences in last 2 visits have been altogether different. It has been a very, very personalized, familial hospitality, which I am not going to forget in my life. I have got so many friends, brothers, mentors here. I thank you all. And to finally, it was Priyanka who was there to welcome me even in late hours with one of his colleagues. And I think this is something amazing, and this is only which can happen in Mumbai. So if they open their heart, the things, it is their love and affection is never ending. Thank you, Mumbai. Thank you, Mumbai Surgical Society. Long live the ASI. Jai Hind. Thank you.
Thank you, President Sir, for the very encouraging presidential speech. The last part of this inaugural function is the vote of thanks. Before I ask Dr. Rajesh Yadav to come and deliver the vote of thanks to the Vice President, I recognize, including me, 2 past presidents of MSS, Dr. Kishore Aryantaya and Dr. Niranjan Agarwal's presence in this hall. Dr. Uttara wants to say something. Yeah, Uttara sir, the behalf of IIM.
Yeah, thank you. And I apologize for a little bit of the protocol this after the chief guest normally speaks. But with his permission, I can go ahead because of a very important aspect. Respected ASI President Dr. Jain, Classic President Dr. Ponte, our personal friend Dr. Shailesh. I think we have been in many programs together, and he's one man who has stood for the doctor community and especially the student community, which I appreciate very much. Then Dr. Pudesa, who is President of IMA Maharashtra State. Dr. Abhay is my classmate right from first standard, we have been together. Dr. Subesar also, I think, is there. And my special thanks to the first president, Dr. Kishore. But without you, I think I would not have been a member of MSS. I still remember he forcibly made me a member of MSS. He used to give me a call, but I would not get the time at that time. So he himself paid my money, which I gave him afterwards, and made me the. So I am standing before you not just as an IMA Vice President National, but also as a member a grassroots member of MSS. Then of course my friends, Dr. Rao, Dr. Kamar, Dr. Shetty, Dr. Yadav, all of you, I think it's great. So this is a time I get to meet the surgeons nowadays after I have got out of the professorship retired as a professor at JJ. First of all, let me congratulate MSS because, gents, let me tell you, when we were junior surgeons, it was very rarely we used to get to learn something new in surgery because nothing used to happen. The only two main avenues were either the MSSCON or the ASICON. Nothing else in between. But let me tell you, great job done by MSS because I myself many a times I'm still learning. I go on to their videos which are there online and even their weekly programs, if I'm not mistaken, which is there, where you get to learn something new in surgery. So let me congratulate the whole group for starting this type of a program for all the junior doctors and people like us who have got out of the teaching faculty now. So this is the only way we can come to learn. Today I was sitting over here and many things as far as foot surgery is concerned, hernia surgery is concerned, some new things also I learned. Now today my main request over here for letting me talk is what is happening. I think you must be aware of what is happening in Rajasthan today. We have been fighting a lot for the rights of doctors all over India. One of our main reasons for the fight with the government was assault up till today. The assault done by the relatives of the patients on the doctors. But since this week, we are now fighting the assault which is directly done by the government of us. They have introduced, not only introduced, but they have passed the right to health bill in Rajasthan. Now, what the right to health bill says is basically that every citizen of Rajasthan is entitled for getting free treatment during emergencies, that is in inverted comma, because defining emergency is extremely difficult, because even a simple stomachache or something like giddiness can be an emergency for a patient. And he can enter any private hospital, any private clinic, any private OPD and demand for a free treatment from that doctor. So this is what that bill, basically the bill says. And we are not supposed to ask for money for giving him primary treatment. Not only that, give him all the treatment, not only our professional, but even the medications which are there to be given to him free of cost. And if we feel that we cannot treat him and he requires a higher center, it is our responsibility to hire an ambulance and escort that patient with our money to that center, tertiary center. So imagine in small places where we have to go for miles, to go to a tertiary center. All that responsibility today the government of Rajasthan has put on our practices. Majority of our surgeons have our own nursing homes. We have built these nursing homes with the sweat and toil of years, not only spending our money but even taking loans, trying to learn in such conferences something new. Invest on those instruments. You know how the instrument, especially laparoscopy, is coming a big way. And we invest in that. The government does not give us anything. No discounted land, no discount in building a hospital. We do not get any special facilities for getting loans from the bank. So it is like any other commercial unit you are supposed to do. And after having done that and set up your own setup, the government expects that you are supposed to treat the patients free of cost. Now what? The government, why did they do that? Everybody asks us that. See, right to health is basically the duty of the government. The government is supposed to give you a right to health. So they are supposed to improve their hospitals, their government hospitals, their semi-government hospitals, so that the citizens can get proper medical treatment. Now, let me tell you, the ground reality in Rajasthan is that it is so bad, the government hospitals over there. They have many schemes in Rajasthan also, but none of the citizens go to these hospitals to get treated. So they were moving to the private hospitals, and because politically it becomes a vote catching gimmick for these people, they have now pushed the whole burden from their shoulders, that is the government shoulders, onto us private practitioners. So that fight you have seen every day, it comes in the papers, even on WhatsApp it is. The whole of Rajasthan today is at a standstill almost for the last 5-6 days. Not only that, when they took out a silent morcha, the doctors, senior doctors who were there from Rajasthan, they took out a morcha, they used water cannons on them and lathi charged them because they were on the road. So this is how the government is treating us. Why I am trying to tell you this is that why are we fighting this in Rajasthan? And that this is all over. We had a very important meeting yesterday in the night with the national office bearers, and our national president also went yesterday to Rajasthan, met the Rajasthan governor, because that is the only way to try to stop this bill or at least get an amendment to that bill. Why we are scared is, if you see in Maharashtra, we have not allowed the Clinical Establishment Act yet to come in Maharashtra. I don't know if you all remember, we had a huge agitation at that time. You were also on the road because they were trying to bring the Central Clinical Establishment Act, which would have been very detrimental for us in our day-to-day practice. We stopped that and it is till date because of our continuous opposition, they could stop it. And one of our main opposition was because they wanted to put a moratorium on how much you could charge the patients. So no other professional body is there a moratorium, may it be the lawyers or the architects or the chartered accountants. Nobody puts a moratorium on them, but they wanted to put us on that, and that was one of the main reasons. Even till today, the CA is stuck because on one side, the so-called citizens group is trying to bring this moratorium in the CA, Maharashtra specific CA bill, and on the other side, we are vehemently opposing it. Now, that was where they put a moratorium, that means you are going to pay something. Imagine in this bill, which has already been passed in Rajasthan, you have to do it free of cost. So you put up your whole setup and you do the job of the government so that the government can get brownie points, can get votes. So it is a very populistic thing that has come, and therefore my request, especially since we have the ASI national president here, we have the Maharashtra president also here, we are now thinking of escalating this agitation. It starts on Monday with just routine black bands and everything. Not only that, we have asked in every area for take out the candlelight march. Why I tell you? Because on the one side, this government is trying to project that these doctors do not want us to bring something which is helpful for the common citizens. So that is how they are trying to project it. So we want to project it to the patients that this is not only going to be detrimental for us doctors, but it is going to be detrimental for the patients also. Because what the government says is that we will reimburse you, but they are not telling us how much they will reimburse, what they will reimburse or anything, and how will they reimburse. All this PMJ and all these issues which are going on, where for months and years we do not get paid for what we have already spent on the patients over there. Same thing is going to happen over here. So what we wanted all of you is to support. We will be giving out all the details of how we want to escalate. Today, all of Rajasthan is shut down as far as hospitals are concerned and doctors are concerned for the last 5-6 days. But I think he is very, very adamant. We have even gone to the speaker. I was there in Delhi when they spoke to the speaker also, and he was also very sympathetic and he understood what the problem was. He spoke to the chief minister, but the chief minister was very, very adamant. So we may have to escalate that. And please support IMA when the IMA gives you a call, because if this comes in every state, I think I heard Dr. Kapoor say one of the last things, the mistakes that we doctors do is ask the children to come to medicine. I think that is going to be absolutely right, because majority of our hospitals are definitely going to be shut down. If the onus is on us to treat all the patients free of cost without getting, we have told the government, those institutions whom you are giving special, land for building, the trusts and everything, All those people you can ask them to do this for you, which is which is there where they're supposed to give 10%, 20% of the debt free of cost. You cannot expect a small-time doctor who has put his own money, and built a hospital to give free treatment. So my request, sir, to you is, I will keep in touch with you and also with you. Please support the IMA because this fight is not, as you said, only for one section of doctors. This fight, just like the Clinical Establishment Act, is across the board. Because let me tell you, there is also a penalty if there is a complaint against you, which is around 25,000 rupees, which you will. And who will decide? It will be the local karyakartas, the district administration, who will decide that you are not given treatment or what treatment you have given is compromised. So let us fight for the rights of, it's high time we stand up and fight for our own rights, because we like to, we are in a cocoon, we like to be in our own practice, own family and all. But then the next generation, I see a lot of young doctors who are sitting over here, the next generation will be very badly hit by that, and that is for that generation at least we should fight for what we are doing. So thank you very much, sir, for allowing me to. Yes. Thank you.
So the struggle goes on for doctors. Thank you, Dr. Uttare, sir. Before the vote of thanks, our host of this meeting, Dr. Mohite, would like to say a few words to us.
To join my teacher, Dr. Sharad Shenai, Kulte, Dr. Kutte, Dr. Shetty, senior teachers, Sute sir, Dadvi sir, academic team, Nayak, Dr. Tharap sir, my friend, Dr. Niranjan. Ladies and gentlemen, a very good afternoon to all of you. It is indeed a great pleasure that Dr. Manmohan Kamath has brought this event to our institute. We are the youngest among the medical colleges in the city. This is the college building, which is a 5-story building with state-of-the-art facilities, as Dr. Kamath said. With enthusiasm of the staff, we are going to have the skill laboratory and other infrastructures. Geeta has planned out an excellent EMS for us. So by next 2 years, most of the things will be modernized. We get whatever we want. We have asked for a robo, one for orthopedic, one for general surgery. This year surgery has got 10 seats for post-graduation. I congratulate the department and the faculty of surgery department. Thank you very much. Have a nice time. I'll proceed with the vote of thanks. Dignitaries and friends, good afternoon. On the behalf of Executive Committee of MSS, I take the opportunity of thanking you all for participating in the 5th annual conference, MSSCON 2023. I thank Dr. Sanjay Jain, President ASI, Dr. Sanjay Kolte, President NOSI, for placing this program and giving us their valuable support. I thank Dr. Sharad Shenai. A special thanks to Pharma Support, to Dean as well as HODs and Department of Surgery, HPTMC, and Dr. R.N. Cooper Hospital, to our AV support and to other hospital staff. My special thanks to our past president, Dr. Kishore, Dr. Naresh and Dr. Niranjan. Finally, to all the members of MSS who came together once again in making this program a success. Thank you.
Thank you everyone. I request all the dignitaries to please take their seats, and we will quickly start the oration, which has been delayed. Can I request all the 3 presidents President ASI, President Masi, and President MSS to chair this session, the prestigious oration of Mumbai Surgical Society.
Authored a book on surgery for the undergraduates and the postgraduate students titled Surgery, Tools, Craft and Craftsman. He was a guest speaker at the American College of Surgeons centenary year at Cleveland Clinic, USA. Dr. Shenoy has been a competitive sportsman before, during and even now. Swimming has been his principal forte. He was a captain of the Maharashtra state swimming team at the junior and senior national championship. He was also the captain of the Mumbai University swimming team at the inter-varsity championship. He was the captain of the winning team at the inter-varsity water polo championship of Mumbai University. He was the vice captain of the Indian water polo team at international championship. He was the gold medalist in 100 meters butterfly stroke at junior, national and inter-varsity swimming championship. 4 times in a row, he was an individual champion of Mumbai University and Maharashtra State. Inter-medical swimming championship 5 times in a row, winning all events. He was selected as a member of the Senate for Sports at the University of Mumbai. He swam a sea race from Malad to Shivaji Park, distancing 35 kilometers during his internship in the record time of 7 hours. He was awarded the highest award in sports in the state of Maharashtra during internship in 1979, the Shiva Chhatrapati Award. He is still a keen swimmer and has participated in the Veteran Olympics in 2017 at Budapest. He has a keen interest in observing the new generation, learn from them, and maybe implement in his own practice their skills and newer knowledge. On behalf of the membership, the executive committee of the Mumbai Surgical Society, we present to you Professor Sharat Shenoy as the orator of Mumbai Surgical Society during the 5th annual conference 2022. Thank you. May I ask Dr. Sharat Shenoy to please start the oration. Thank you, sir.
Very good afternoon. Yes, I'm extremely sorry at the outset that I am basically born with a hoarse voice, and after the attack of laryngitis last week, the hoarseness has become a croak. I'm very sorry for that. At the outset, a very good afternoon to all the dignitaries, the President of the ESI, President of the MASI, the President of MSS and other dignitaries. I also like to give a warm welcome to the office bearers of the MSS and also all the delegates and my colleagues sitting here in the audience. At the outset, I would like to thank the organizing committee for having given me this opportunity to speak at an oration. I am humbled and I felt privileged, and I really want to thank the organization for helping me with this oration. Then I'm going to speak on my conundrums as a general surgeon, and I'll make you understand the reason why I picked up this topic. The conflict of interest was none, because all the cases that I'm showing over here are my own cases, and this I've got not a series as such, but I'm going to present certain cases which in my practice I have come across. I've been practicing as a general surgeon since 1982. When I became a resident, I trained in Nair and then in KEM. Practicing presently as a consultant in Jaslok, Rajawadi Hospital, Fortress Raheja and Hinduja Healthcare. I've operated a variety of cases from HFN to abdomen to chest to urology to reconstructive surgeries and a huge variety including neurosurgery. I've trained in endoscopy and laparoscopy, basic as well as advanced robotic surgery. Now I'm going to start with a series of cases from the abdomen and tracing you to other options later on. If I think of an abdominal surgery cases, I would like you to trace through the cases that I've done. These are one of the cases, it's not that, and all of them are unique in their own way. The GI tract extends from the GI tract to the mesentery, to the pelvis and to the peritoneum. Let me first start with the lesions of the midgut. More than 90% of mucosal surface of the GI tract is provided by the small bowel. Surprisingly, only 2% of malignant lesions of the GI tract are seen in the small bowel. 60% of small bowel tumors are benign, most commonly they are leiomyomas. Let me come to the first case. A 63-year-old female patient had dyspepsia, loss of appetite for 2 years duration, no signs of acute or subacute intestinal obstruction. But she had comorbidities like diabetes and hypertension. She was a tobacco consumer. This clinical picture also, she had epigastric pain since the 2 months, dyspepsia, bloating, irregular bowel movements, off and on, urgency for defecation. When we did a sonography for her, she showed an ill-defined echogenic mass in the right hypochondrium, superior medial to the right kidney and inferior to the gallbladder. Further evaluation by a CT scan had to be done. The CT scan showed the lesion to be in the lumen of the duodenum. It was a massive lesion in the lumen of the duodenum. That was the other view of the CT scan. So I did an endoscopy for her. I found a huge nodule, a polypoidal lesion in the first part of the duodenum, extending all the way to the second, to the third. Probably I didn't know where it was going. I took a biopsy from it, and histopathology came as a Brunner's gland nodule. So the contemplation was whether I should delegate to the endoscopist to do a snare. It was really difficult because the tumor was huge. The snare going around that was going to be difficult, so I did an exploratory laparotomy. I did an enterotomy and I passed in a laparoscope through the enterotomy. My only worry and concern was if it was attached, the pedicle was attached to the second part of the duodenum on its medial side, I would have to go for a ripples rather than doing a polypectomy as such. There was a lesion which you could see on it up, and then the diagrammatic representation of what I do. The enterotomy incision extended onto the duodenum, the polyp was delivered out of it, and I finished off with the Finney's gastroduodenostomy. That was the intraoperative tumor mass delivered, and this was the Finney's gastroduodenostomy done. This was the excised mass. This excised mass was about more than 5 inches in length. It had extended from the first part of the duodenum right to the third part of the duodenum. That was a cut section, and surprisingly, the duodenal polyp turned out to be a Brunner's gland hamartoma. A little bit about the hamartomas. There are only about 150 cases in literature. They form approximately 5 to 10% of benign duodenal tumors. They are usually 1 to 3 centimeters. Greater than 5 centimeters are rare. This was more than 5 inches. The second highest in the world, China had quoted a 7.5 inch duodenal hamartoma. The age is normally between 40 to 60. The incidence between male and female is equal. The cause for this is usually hyperacidity, H. pylori infection, hyperplastic reaction to inflammation of the Brunner's glands. Let me come to the second case. 40-year-old male patient, symptoms of subacute intestinal obstruction. There are distension of the upper abdomen. The ESI was raised. The tuberculous IgM was raised. The X-ray chest was normal. The abdomen showed an X-ray solitary loop of jejunum, something of a subacute intestinal obstruction. A barium was done. A stricture was demonstrated with the jejunum with gross proximal dilatation. Did a CT scan, the same evidence of subacute obstruction was seen. Jejunum was obstructed. So we put in a laparoscopy. We found a lot of adhesions. When I was separating the adhesions, we found a healed perforation, which inadvertently got opened. I converted to exploratory laparotomy. The adhesions were separated. The stricture in the upper jejunum was identified. The resection anastomosis was done. And then came the surprise. It was aspergillosis stricture of the jejunum. This aspergillosis is usually an infection or an allergic response to the fungus aspergillosis. They usually grow on dead leaves, stored grains, or decaying vegetation. When I went back to the history of this patient, he was working, he had a shop of a kirana shop in Ratnagiri, where they stored grains. Probably he must have bought from there. It rarely occurs in those who have a normal immune system. This person had a normal immune system. And the usual form of aspergillosis is pulmonary, which is allergic, aspergilloma, or pulmonary invasive. All of them are found in the lungs. This was in the intestines. Of course, we went and did all the IgE levels, aspergillus antibody tests, galactomin, all of them positive. This was done about 9 years ago. The patient is fine. He still comes once in 2-3 years for a follow-up. The third case. This was a 42-year-old female patient. Attack of gastroenteritis treated by the family physician. For 4 days she got treated, then she got a severe bout of bleeding per neck of fresh and mixed blood for 1 day. She had come to my nursing home, not my nursing home, but the place that I go to. She had presented with hypotension, tachycardia, and hemoglobin had dropped from 10 grams to 6 grams per center. And these facilities were transferred to a tertiary center. Emergency, when you got the CT scan done, that was the tumor sitting there. This was in the jejunum, but not in the lumen of the jejunum. It was outside the lumen. An emergency exploratory laparoscopy had to be done. That was a tumor that's seen there. On surgery, there was a polypoidal growth in the mid-jejunum on the anti-mesenteric border. The adhesions were found around it, they were separated, and this was found to be the only source of bleeding in the GI tract. A resection as was done of the segment concerned. The specimen showed the bleeding into the lumen of the tumor. This was the tumor on the table. This was post-resection. This was vipassana to demonstrate the bleeding, and that was the bleeding seen inside. Then came the supplies. Of course, gastritis and stromal tumors was the diagnosis. Tumor of the jejunum was seen positive. A little bit about this. They are commonly seen in the stomach and the duodenum, synonymous with a particular distinct phenotype associated with a mutation in the tyrosine kinase c-KIT oncogene. The tumors are very sensitive to tyrokinase antagonist imitant. I started her on that. 2 years I gave her that. She's absolutely fine. This is almost about 8 years now. The tumors are with mutation, exon, etc. Now, let me come to the fourth case, a mesenteric mass. 50-year-old female patient presented with non-specific pain in the right iliac fossa with no bladder bowel symptoms. There was a large lump in the right iliac fossa extending to the lumbar region, non-tender, soft mass, no guarding, no rigidity. Clinical impression was a mass in the mesentery at the IC junction. A USG was done almost 12 by 12 hypoechoic mass in the right iliac fossa with increased vascularity and separate from the bowel. Impression was a mesenteric tumor, very lymphoma with a dilatation of the PC system because of a mechanical pressure. We did a CT scan. The CT scan showed a very large, well-defined soft tissue mass in the right flank. They also said probably a lymph node mass of a lymphoma. That was the CT scan. A huge tumor that you see there in the mesentery. That was another view of the CT scan. A diagnostic laparoscopy was done. We found a large ileal mesenteric mass near the IC junction. Biopsy was taken. Histopathology showed it to be a spindle cell neoplasm. It was c-KIT negative. We did exploratory laparoscopy for a large mass in the mesenteric IC junction, extending behind the colon into the paracolic gutter. The mass was removed along with the adjoining bowel. The right radical hemicolectomy of the mass was done, either transfer bypass was done. There was a diagrammatic representation of the tumor sitting there behind the colon. Histopathology showed it to be a leiomyosarcoma grade 3. It was arising from the mesentery and the peritoneum. Chemotherapy, everything was given, everything possible was given. 3 years we struggled with the patient, we lost her ultimately. A little bit about leiomyomas and leiosarcomas. It's a very interesting finding. Leiomyomas have equal incidence in males and females. They are predominantly in the ileum. They are mainly asymptomatic. Symptomatic leiomyomas are usually malignant. This is usually leiomyosarcomas. 75% of the small bowel tumors at necroscopy are benign. That means those are ones which are asymptomatic. 75% of tumors at surgery are malignant. This was quoted by Baring and Welch. Then we come to the fifth case. 32-year-old female patient presented through a gynec reference, non-specific pain in hypogastria, disturbance in the menstrual cycle, clinically lumped in the hypogastria, arising out of the pelvis but not from the uterus or the adnexa. They were bimanually palpable. Again, the investigation, the USG showed a mass in the pelvis. IVU showed the mass displacing the left ureter, not causing hydronephrosis. That was the IVU picture of the bladder, and that was the mass sitting there in that area. Another view of this displacement of the bladder and the left ureter. So did a CT scan. It showed the mass going right down to the pelvis. This is the next plane going down over here. Exploratory laparotomy was done. The mass was going behind the bladder, between the uterus and the vessels, and towards the obturator foramen. When we excised it, histopathology turned out to be angiofibroma. I'm going through this because I just want to present something to you later on. The sixth abdominal case, interesting case again, a retroperitoneal mass. A 45-year-old female patient presented with an abdominal mass in the left flank. No hematuria, no frequency, no pain, no bowel symptoms. A bimanual examination was palpable, palatable, and moved with respiration. Clinically, retroperitoneal mass, possible kidney origin, or the soft tissue. So CT scan showed a large soft tissue mass arising in the retroperitoneum, displacing the kidney inferiorly and causing an atrophy of the kidney. That was the mass that was seen. Huge mass sitting there. The kidney was completely displaced. That was the vertical section of the mass. This was a diagrammatic representation of the mass. It was almost 18 inches, 1.5 feet in the abdomen, displacing the diaphragm to the fourth space, displacing the stomach, spleen, everything to the right. Colon was to the left, to the right again. Then extraperitoneal exploration of this mass was done. The mass extending from the diaphragm, which was displacing the fourth space, to the pelvis, the mass had completely displaced and compressed the kidney, thus had to be removed with the mass. Histopathology came as a leiomyosarcoma. Something interesting about this patient a little further. She refused any kind of chemo or radiation. She lived for 12 years after that. She was 45. At 57, she came back to the recurrent mass. This too was in the same position, retrogastric. This time we went transperitoneal. It was almost a 6.5-inch tumor, which she removed again. Again she refused, it was leiomyosarcoma again. Again she refused any kind of chemo, etc. 2 years later, we lost her. Now we'll come to the thoracic cases. There are all thoracic cases, effective surgical as well as conservative management. The first case. The 50-year-old male patient, hypertensive, presented with high-grade fever with chills. On examination, the air entry showed the right lower lobe absent air entry. The clinical impression was a pneumonia or possibly a effusion. He had a past history. Yet he was a chronic alcoholic and a smoker, had been diagnosed for calculus cholecystitis with chronic pancreatitis and pancreatic calculi. I had operated him for the same problem 2 years ago before he came to this presentation. With a cholecystectomy and lateral pancreatico-jejunal, a few stores were done through a rooftop incision. I got to be investigated this time, an X-ray chest showed an effusion. A tuberculosis suspected by the chest physicians, AKT was started. Severe breathlessness, and there was a need to aspirate that way. On aspiration, it revealed about 300 cc of pus came out. So I put in an intercostal tube to drain the empyema, and AKT was continued. Pus was sent for routine and AFP culture. This was pre-chest tube, and that was post-chest tube. We followed up this patient. 1 to 2 liters of pus drained daily. 3 to 4 days later, oral intake of beetroot juice came into the ICD tube. Esophageal leak was suspected. The CT scan confirmed the lower third esophageal leak, and I probably felt this must be some Burab syndrome in view of this alcoholic status. A leak via the mediastinum, a CT scan confirmed the lower esophageal leak, and the leak was going via the leak, went into the mediastinum, went into the pleura, and became an empire. This was refilling of the pleural space. So we used the oral contrast, and there you could see the leak coming down from here and that to the esophagus. This was again the leak which was showing there. Now, the dilemma which I faced, how to tackle this patient. He had a rooftop incision with a lateral pancreatic tracheostomy. Multiple additions, there's no doubt about that part. Either I do a thoracotomy to tackle the fistula, or I do a total esophagectomy with a gastric pull-up, or a colonic interposition, or do hyperalimentation to dry up the fistula. I took my third option. I did a feeding jejunostomy for him, kept him in my mouth, and enteral hyperalimentation was started. 6 weeks of enteral feed, the CT scan repeated, the leak had lessened. 8 weeks later, did an endoscopy. The fistula was seen at 31 centimeters as against what we saw in CT scan previously. So it was a middle third esophagus. And endoscopic clipping of the fistula was done by an endoscopist colleague. That was a leak which had lessened after 6 weeks. This leak lessened further. That was the fistula that was seen, that was the esophageal cardia. That was the middle third. And endoclips were put in. 3 weeks, 2 weeks after the clipping, we went in again, we saw the fistula closing. 3 weeks later, the fistula had completely closed. Final outcome, enteral feeds were continued. 3 weeks after clipping, repeat fistula, the fistula had closed completely. Patient is an oral full diet. Final diagnosis was esophageal, mid-esophageal traction diverticulum, which had leaked, perforated, went into the media cell, into the pleura, and became an empire. Now comes the question, is this patient, in the relapse of 2015, I operated, did an gastrostomy, etc. He's come back to me, absolutely fine with the esophageal front, abdominal front, except he's got an incision with the hernia. So I told you, take your time over it, please don't be in a hurry to come to me. Go anywhere else if you want to. Okay. The thorax case 2. 25-year-old male patient, sudden onset of dysphagia and breathlessness after the first swallow of food. This is typical of a gastric volvulus. This patient was seen in Virar by a student of mine. The air entry on the left hand side was absent. The X-ray chest was diagnosed to be a pneumothorax, and he was asking me whether I should put an intercostal drain. The first thing I told him when I saw the X-ray, I said, please don't do any such things. Please send him to. I took him to just look, and here was tertiary center. The picture was seen. Huge displacement of the stomach. X-ray chest, gross displacement of the stomach. CT scan showed a gastric volvulus. That's the CT scan. That's the next CT scan. Then what do you do for this patient? Is another lateral. In abdominal approach, the contents were reduced, diaphragm sutured, abdomen closed, recovery complete. This was done in 2005. Incidentally, 2023, just beginning of this month, he came for a routine follow-up just to meet me. He's 47, 43 years old now. He's absolutely fine. Next comes urology cases. Have you done urology as a general surgeon? Yes, we have done it. So, the odd urology cases in the field of general surgery. A foreign body in the urinary bladder. This 46-year-old female patient, general exam, she came with repeated urinary tract infection. There was no evidence of any hematuria, gravelly, or bleeding for it. The only positive thing was that 20 years back, after a fourth delivery and a DNC, she decided to put a copper T. Then she completely forgot about the copper T. And 20 years later, she came back with a calculus in the T of the copper had migrated from the uterus into the bladder, over which there was a foreign body. I did a cystoscopy, and on cystoscopy I found stones sitting there in the lateral wall of the bladder on top of a foreign body. And just like I teach all my students in a simple form of mnemonic, to harder stone to softer stone, to larger stone to smaller stone, to younger patient to older patient, infected bladder, contracted bladder, stone in a diverticulum, and stone in a foreign body are not to be tackled by cystolithotripsy. You need a cystolithotomy. Incidentally, Bharat was my colleague that time in Rajawadi. He did the cystolithotripsy for this patient, and that was coming out of the stone, and that was the property with the foreign body. Second case, urology. 38-year-old male patient, advocate by profession, presented with a pain in the urethra, burning urination, repeated UTI, history of operating for hypospadias as a child. A turn-up warming was done with a flap going inside the urethra. On examination, we have periurethral swelling, of course, diagnosis what a periurethral abscess. X-ray showed a KUB in the urethra, X-ray KUB showed a calculus in the urethra. Ascending urethriculum was done, stone was seen in the urethral diverticulum. That was the stone in the urethra. There's a oblique view, again, once again, the stone there sitting there. This was the ascending urethrogram, and then you see the stone in the diverticulum. You know, urethroscopy for it. It showed a stricture in the penile urethra at the site where the urethroplasty was done as a child. Proximal to it there was a diverticulum, in the diverticulum sitting the stone. Catheter, urinary dilatation was done. The stone was removed over the skin incision, catheter placed. 3 weeks later, the fistula closed. Is still fine, comes once a year for urethral dilatation. Third case. 15-year-old male child, primary lymphedema of the inferior extremity, congenital Ramon penis. Incidentally, this was not my case, but the Mahendra's case when I got to assist him. So that was the Ramon penis that we saw, and ultimately a reconstruction of the penis was done. If you could see on the previous X-ray, previous leg, you could see the primary lymphedema on this leg. Okay, on this leg you can see the lymphedema, primary lymphedema you can see. There. Let's come to the head, face, neck cases. Though challenging, have been managed as a general surgeon. The first case, oral cavity lesions. 34-year-old female patient presented with a lump in the tongue and anterior 2/3 of the tongue. Non-painful but difficulty in speech and swallowing. On examination, a firm mass in the tongue was seen, no lymphadenopathy was there. There was a CT scan and that shows the lesion in the anterior 2/3 of the tongue. That shows the lesion anterior to the tongue. Partial glossectomy was done to excise the mass in the tongue. Histopathology turned out to be cystosarcosis in the tongue. The second case, 35-year-old female patient, soft swelling in anterior tank of the neck, no fever, no pain. Over a period of 1 year, the swelling, there was a gradual increase in the swelling. On examination, the soft mass around the carotid, near the upper deep cervical node. Swelling was non-pulsatile, there was no bruit, but appeared non-lymph nodal. Neck mass of unknown etiology was the diagnosis. So we got a sonography done. We did a CT scan and we found that this was a lesion sitting encircled by the vessels, the carotids. We explored the neck. The mass was seen to be encircled by the vessels. Separated and excised histopathology was a neurolemoma. Now this comes the giant abdominal hernias. We had a healthy discussion in the morning. This was the patient which was an incident. He had a renal transplant done some 5 years back, followed by when somebody had an abdominal laparoscopy for suspected tuberculosis. He was given a AKT treatment, followed by that the hernia developed from the both sides. And these are some of the ones that I showcased. We used to do a regular muscle relaxing incisions. We used to never know that it was called as abdominal wall reconstruction. We had given good results on almost the mesh was placed always over the peritoneum under the retrogastric muscle. And we have done innumerable cases giving equally good results. Regarding upper GI and lower GI scopy, upper GI scopy I have done over 5,000 since 1984. I continue to do so even today. Of all my cases, I do the endoscopies. The colonoscopy is over 1,500 in the last 8 years. Minor procedures like sclerotherapy, biopsy, and euthanasia dissection have also been done by me. Oncology, reconstructive surgery, over 1,500 cases of oncosurgery since 1984. Breast, thyroid, esophagus, stomach, large bowel, rectum, anal canal, liver, gallbladder, bile duct, pancreas, retrobladder masses, renal malignancies, bladder malignancies, reconstruction, including a neobladder, final leg corrective surgery, and gynecomastias too. Some discussion was going on final leg. If you notice, this patient can come to me. Of course, this I used to do when I was a lecturer in Kenya. A control was done in the upper leg. And what I did was I excised this and put a skin down for Charles. So I go get. I got good results. I've done more than 25, 30 cases. probably Swami etc. must have been there when he was my registrar in KEM. Now, contemporary surgeries, laparoscopic surgery, more than over 8,000 laparoscopic procedures in 1991. 5,000 gallbladders and others like appendix, mesenteric cyst, polycystic livers, diagnostic laparoscopy, including for Cox abdomen, laparoscopic orchiopexy. I've done over 5,000 gallbladders, appendix, mesenteric cyst hospitalizations, esthesiolysis, polycystic liver, diagnostic laparoscopy for Cox abdomen. Incidentally, 2014, I've gone to America, the American College of Surgeons. They asked me to speak on tuberculous peritonitis, and I gave them the importance of laparoscopy and how to come to achieve a diagnosis. If you look at this picture, these are typically adhesions. This is tuberculosis, and this is typically metastatic momentum, which you see here. So, laparoscopy plays a great part in diagnosis also. This I did just end of February, a polycystic liver, de-roofing of the polycystic liver. She had polycystic kidney as well as polycystic liver. Left lobe was hugely enlarged, compressing on the stomach, causing vasovagal swelling. So the knee surgery was done. Laparoscopic orchiopexy was done in June 1991. Over 250 cases done. Very useful for diagnosing of intraabdominal testes, as the case of true hermaphrodite. Have I contributed anything to general surgery? I had gone to Bombay Hospital when I was a resident for a hepatobiliary conference. There was a surgeon called as Stig Benmark. Very impressionable surgeon, so I went to take his autograph. And this is what he wrote on the autograph: simple is effective. That's the reason why I thought, let me label this. A very, very simple technique for piles. I just take the pile mass out from the fundus to the pedicle and come back and tie it up. Something like we do for Millen Walker in cases of transesophageal underrunning of esophageal paralysis that we see. I've done over 4,000 cases of piles. One catheter, 15 seconds per pile mass, 45 seconds, I mean almost a minute and a half, pile surgery is over. It gives extremely good results. I've got no interest. I still do it in one catheter. That's all it costs the patient. The second case, I called this anal fissuroplasty was the name given by Ashwini, who was my colleague that time working with me. She was the one who suggested this name. This lady was treated by a quack. She had burnt the piles and she had got a fissure in the sentinel pile. So I thought, let me do something. I cut the internal sphincter like you do for sphincterotomy. I refreshened these edges. I completely scooped out all the infection from the sentinel pile, rotated that flap into the fissure so that there was no sphincter, and there was no stricture of the sphincter. Worked very well. I've done more than 50 cases of this with good results. For pulmonary sinus, I always have a feeling that if I can make this natal cleft shallow or wide, the hair follicles will not settle. It's invariably the recurrence of because of the narrow natal cleft. So very simple procedure, a triangular incision was taken, on the buttock the incisions were extended and the advancement flap was done upwards. You have good results, no problem at all. Anything else I have contributed? Humble contribution to general surgery, one author book and available on Amazon, but yes, whatever I should teach, I have written in that. I owe a Sashtam Dandavat to all my teachers who made a difference in my life, which made me what I am today. I should always tell all my students one thing: there are teachers and there are teachers. There are some teachers who teach you what not to do, and there are some teachers who teach you what to do. Even I had three impressionable teachers who came in my life. One of the YMK, he was a mentor when I was a postgraduate student mentoring. He used to always tell me one thing: whatever surgery you do it with passion, do it with, take your own time, do it as if it's your first and your last surgery. Don't go for speed, speed comes with practice. That was why I came from, I'm sorry. C.V. Patel was a mentor par excellence. I worked with him. He has held my hand or he was with me for suturing of a punctured heart, of a stab injury, to a punctured lung, to thoracotomies, to helpless neck. We have done total cystectomies in KEM. he used to tell me one thing: there is nothing that I cannot teach you, and that which you cannot learn from me. That was Dr. C. Patel. And of course, Dr. Mahendra, all of us know, he is my mentor, omnipresent. I've seen him since I was an intern. I worked with him. Then I became the assistant honorary. I still work with him. Every day I learn something new from him. It's always, from what he taught me, I understood that what he meant to say was, work under your circumstances, but plan for the future. That was Dr. Mahendra. But what is the message to remember? I remember Shakespeare and Hamlet. To be or not to be, that is a question in life. And that's what I had, a conundrum or a dilemma. To be a general surgeon and serve the masses, or be a super specialist and serve the classes. And deep from my heart, I got this message: I'd rather be a common surgeon and spread happiness to many than be a superman or god for some few. Dhanyavad.
Thank you, Dr. Sharad Shinoyan, for such a wonderful oration. That's what orators are made of. I request all the three presidents and Dr. Abhay Dalvi to felicitate our orator. I request Dr. Mandare to come down for a photograph with the orator and the Executive Committee of Mumbai Surgical Society for a group photo along with the presidents of state and national.
I'd like to invite my panelists for this session, which is Surgeons Beyond Surgery. And the panelists are Dr. Preetam Pathare, Dr. Anand Nande, Dr. Vinay Mende, and Dr. Simi Saxena. I'm not going to talk anything about their excellence in surgery, we know it all. And without wasting any time, since we are really running short of time, I'd just like to go ahead with the session. So, Dr. Vinay Mende, sir does a lot of things, and he is a trekker, a footballer, an actor, a cyclist, and has also recently added a new skill to his ever-growing list of skills. And this is what he is doing right now. Okay, this is good one. And so if anybody says age is not a number, you have to look at sir and say, yes, age is not a number. Okay. So, sir, now, but going back to your first love, can you tell us a little bit about football? How did you start playing football and your club?
In my 8th standard, I went to stay in Western Railway quarters at Lower Berth. As you know, in Maharashtra or in India, especially a Marathi person, has no exposure to any other game than cricket. But in Western quarters, it was a cosmopolitan society. All my friends were mixed up, and so there we started playing football. And even as a 14-year-old, I could play with Western Railway team, which from that time used to play for Harwood League, which was the higher mostly Mumbai. Later on, I continued to play in college and medical college also. As you know, there is not much of sports, so you can easily gain entry into the football team. But we, 3 or 4 of us, regular football, we had to gather people who could just run and kick the ball and make up a team. But during my time, first time and last time, the GS Medical College team came into the quarter final of the intercollegiate. And that's why we could take our team to Patiala for All India interview.
So during
But-
COVID,
Okay. No, but later on, when after I started practice, I could start playing at Shivaji Park, where a group of boys were playing, and we joined and we started a club, which was known as Dadar 11 Club. And we entered the division. In 5 years, from 5th division, we reached the superior most division, and we are still there.
and sir, along with a few other coaches, they do a lot of coaching, football coaching, and this is free football coaching at Shivaji Park. So,
Yes.
why don't you tell us
This
about
is a good thing that came out of COVID. Because COVID, there was a lot of lockdown, everyone was locked up. When it opened out, I started taking my grandson to Shivaji Park to play. And my friends who had by the time became coaches, they brought their grandsons. And people who were watching us playing football, so one by one, they started asking us that whether they could send their children, and bigger children also came. And at the time, we had 140 kids from 5 years to 17 years who we started structured coaching free of cost.
So if you have to get anything done from sir, especially getting to assist you for a case, it has to be nothing after 5 o'clock and before 7 o'clock. So this is how his group of kids has greeted him. This is, they are celebrating when sir was got the ovation, when we came to know that he got the ovation at MSSCON. So Dr. Sini, were you always athletically inclined, or how was it that you got into running and at what age?
Oh, so running very late, but I'm a swimmer since childhood. So I started my swimming from National College of Physical Education in Gwalior when I was very small. And later I joined medical school, and after that didn't get any time. So I could not pursue that. But in 2015, I started swimming again, and that's what I entered into this fitness journey.
Great. So they say, how do you know if someone ran a marathon? Don't worry, they tell you. But it's not true about this woman. How many of you all do really know that she runs marathons? Okay, see, hardly anybody knows, okay? So, tell me, what is it that you enjoy most about running?
See, running in the morning, you get to see the sunrise, which is really beautiful. If you go to Lonavala Hills in the morning, the sunrise is really beautiful. Then the scenic places in Bombay, if we are running, the good routes we take. And then we enjoy the company of the runners, the co-runners.
Yes.
And the thrill I get, the buzz I get after that takes me all day. I'm so happy after that.
Yes, so this is a very short video, and you're going to see how happy she is when she's running. And it almost wants you to get onto the roads and run. So it's not always safe. Unfortunately, we all know what has happened recently. So how do you manage that? When you're running very early in the mornings, and with your long runs, you have to really start early. So how do you manage the safety aspect?
Yeah, that's what after that accident, the running fraternity, we all are really disturbed. normally, like what we are taught, like my coach, they direct us to run against the traffic. Like if the traffic, we are running on the wrong side. But this doesn't apply when we are cycling. But when we are running against the traffic so that we can see if somebody is coming, the car is coming very fast, we can at least save ourselves. So that I want to really tell everyone that whosoever is just taking up running should always run on the wrong side, should run on the opposite.
Against the traffic.
Against the traffic.
See the outcoming traffic.
Yes.
Incoming
Incoming traffic.
Yeah. Now, how do you keep yourself motivated? Doing the same thing over many years, does it require any level of pursuit or kind of pushing yourself?
Not at all. In fact, running has changed me completely. My perspective, like more commitment is there in running. So I've become really, after taking up this running, I can take up any challenge. I'm bold now, and also it teaches many things like getting up in the morning, punctuality, perseverance, all these things.
Great. Dr. Nande is a classical singer as well as a teacher of classical music. And so, at what age did you get into singing and what was your inspiration? Can you tell us a little bit?
Well, I have been singing from my childhood. I realized very early in my life that I could sing well. And during the school gatherings and competitions, I have always been singing in different schools, colleges. In the Grand Medical College, we had a music society. And the 3-4 years that we were competing there, we got all the prizes. So, music has been there with me right from my childhood. What was the second question?
Who inspired you? Your inspiration?
My inspiration. It's difficult to say that, but if you want to see the childhood inspiration, it would be my mother, because she had also learned classical music. She had a very sweet voice, and probably I have inherited that from her. But also, I was interested in music right as a child. So I think there is some genetic, some genome has happened in me, which is responsible for that.
So, as a classical musician, how important is practice and discipline? And with your schedule, do you manage to regularly do riyaz?
Yes. See, I started learning classical music in a very structured manner only when I came to Mumbai. My father was a district judge, so we used to be in different district places. I never came to Mumbai till the age of 20 or so. But till that time I used to sing, but without understanding the anatomy of music, the Saregama Padhanisa business. It was only when I came here in second MBBS because of my father's transfer to the Bombay High Court that I found my teacher, Pandit Dinkar Kaikini, in Bharatiya Vidya Bhavan, a very renowned singer and a scholar of the Agra Gharana of singing. And then with him I started learning and learned continuously for 7 years. Even during my second, third MBBS house post, registrar's post, I used to go in the evening whenever I found time and learn from him. I gave exams because that gave some discipline and became Sangeet Visharad, which is equivalent to BA in music.
So, as a surgeon, what important role does music play in your life?
See, our surgeon's life is very stressful, and I find that music helps me to relax. It has a very healing effect on me. It also helps our patients in our nursing home, in the operation theatre. We play music, and our patients invariably tell us that they feel very relaxed. Actually, one patient, just before anesthesia, we were playing Bhimsenji's Abhangavani, and after the surgery, he said, I felt that even if I die now, it doesn't matter because I am listening to Bhimsenji. So people tend to relax, and it has an effect. It's like a meditation for me, So it has a good concert, a good program, always has a very relaxing effect on me.
So much so that when I come home from a good concert, my wife can tell whether it was a good program or not just by looking at my face.
So, you are so immersed in classical music, and as things stand today, knowing your capabilities as a classical music exponent and teacher, if you could turn the clock back to the day that you started out as a student in first MBBS, would a career in classical music have been a possible alternative?
Absolutely possible. Actually, my Guruji, Pandit Kaikari, told me that he hasn't seen a student like me in the last 50 years who could carry his Vidya forward. So he wanted me to become a classical musician. So it was definitely possible. However, I also was good in surgery. So I was good in surgery, I was good in music, and you know that in this one lifetime, you can excel only in one art. And therefore, I decided to keep this as a serious hobby, but continue with surgery. Actually, at one time, I arranged a meeting between Professor Srikhande, who was my surgical guru, and Pandit Kaikini. I told them, you decide what I should continue. So Dr. Srikhande made a very wise statement. He said, he told Panditji that if Anand becomes a musician, he can't do operations, but if he becomes a surgeon, he can still sing.
That's important.
Yeah.
Fantastic.
Very wise statement.
Yeah. So we are just going to give you a little glimpse.
It's all right, it's all right.
If you do live singing, so you can do it right now. You can sing right now.
That you have
You can go to my YouTube channel, Anand Nande, and you can hear the entire program.
Oh, great. Fine. Yeah. Okay, so Dr. Bakari, tell us a bit, since you are also in music, can you tell us a little bit about your music band and your favorite musical instrument?
When I passed my fourth standard scholarship, my parents gave me bongo, bongo as a percussion instrument. And since that time, I have started playing bongo. And from fourth standard to seventh standard, I was a Balmond student. So in front of Balmond, there was one building where we used to go to Mr. Jari Patke, who taught me tabla. For 3 years, I was learning tabla with him. And later on, it's been percussion is my passion. Even in the school, on your benches also, we used to, keep on putting our hands and create some music in the school also, in the class also. And later on, I started liking more, so I bought a Congo, which is a 3 thing. Then I got a dholak, dholki, and this what I'm playing right now is an octopad. So that's a very versatile instrument where you can create a lot many sounds. And I took a training from the guy who's sitting next to me on the Congo for this octopad. And this is first photograph is just clicked day before yesterday or day before by I think Mahendra sir when I was Bajaving Dhol at Delhi's Hernia conference, and sir has I didn't know that, I didn't notice also.
So I'm going to take the liberty of just starting this video once again, Dr. Nandes. He's just connected this thing and we just
Yeah.
So, Dr. Preetham, when did you realize that you were artistically inclined as far as your paintings are concerned?
During school days, my drawing teacher saw that I can draw well. I can do some paintings, and I represented my school for the drawing competitions. And the intermediate and elementary, I have just got B grade in both the exams. I didn't get A grade or something. And then later on, medical career, 11, 12, and till the time I entered JS Medical College, there was no brush or pencil in my hand. Suddenly, first MBBS, I did 4 pencil diagrams of Durga Kote, Dimple Kapadia, Smita Patil, and one more I forgot, which has been displayed in the Marathi Wangmay Mandal of JS Medical. And then there was one Dhaigude Memorial Prize competition for painting, which I took part in, and then I painted axilla. And that time, one of the drawing teacher where I used to stay in Duruvadi, that particular drawing teacher was from municipal corporation municipal school. He taught me one technique of using Fevicol for painting, and I used that Fevicol, meaning pectoralis major and pectoralis minor. First of all, I drew that. Then I put Fevicol, allowed it to dry for 1 day. Next day, I put a serration to the other end of the brush and to show muscle lines. And then I put a burnt sienna color on that. No one used to come in your touch because it used to appear like this. That muscle is still right now cut and it's wet. And the story behind this I want to share with everyone is that when I passed my MBBS, I got good marks and I was getting surgery absolutely, and I came to the notice board to see that my marks were XYZ. I was not believing because they were not right marks written there. There was not XYZ, there were XYZ plus 10. I said, this is something. I rushed to because I didn't want this mistake to take place, and then I rushed to the office of JS Medical, and they reminded me, you got Dhaigude Memorial Prize, first prize for that axilla drawing, and for which this 10 marks are given.
So does being a surgeon influence your works of art?
Definitely, as you see that you cannot erase your incision. So when you take a line on the paper, you should not erase it. The way you have to be precise in taking incision, and you have to go ahead. You cannot come back.
Yeah.
So that's why the paintings are generally don't use much of a erasers.
So Mendere sir, many a times in the evening, when he doesn't feel like driving, he comes to take rounds on a cycle. Yeah. So in Sushrusha, you may many a times see him on his cycle. So sir has also done this great long cycling trip. So he's going to tell us a little bit about that.
Actually, I have continued cycling since childhood, and I was using it as a mode of transportation rather than being a sport or fashion. Because in the first 8 years of my practice, I can tell now that I could not afford four-wheeler. So I had a scooter and cycle. And as you know, Shushrusha has got no parking. You know the roads of the other. So best way to visit Shushrusha also was on cycle. I would go to play football on cycle. So that was the way. And then, because Milind Bede, countryside, there is adventure tourism, he wanted to take 80 people NRIs on a trip from Alibag to Goa. And he wanted Reiki for that. And he saw me cycling, so he said, will you come as a doctor for that tour? I said, I will not come on that as a doctor, then I cannot cycle. So I went with a group of 23-24 people from Alibag to Goa. It went by coastal roads. It was 500 kilometers over 5 days.
At any time during this journey, did you ever feel like, what am I doing?
Oh yeah. As you know, the Konkan roads, they're all ups and downs. So after third, fourth day, there was a young fellow with me. I said, Sir, bagitla ki doka firta. So he was better than me. He said, Sir, cycle bagitla ki doka firta. And you might have seen this because at the end of that, after the fourth day, at near Dapoli, we had halted, and there was next to the tent there was a river, and all of us went to swim, to take bath really. I can't swim. So I asked for a soap, and it fell off my hands. So I said about soap गिर गया देखा तो डॉक्टर बोल रहा है तो he gave another soap and that also fell down. I said what the hell is happening? Then I realized that I got ulnar palsy. So I just did not tell anybody. I went to my tent and one fellow came. Doctor ये क्या हो गया? I said don't worry. I also got the same thing. And 5 of us had this distal ulnar palsy. When I came back, I showed orthopedic surgeon, plastic surgeon. First thing, everyone cursed me, what the hell you are doing, kuch bhi karta hai. And they started telling me, you take this steroids, this, that. Then I googled and found that there was a RCT on cyclists. They made cyclists travel 500 kilometers. And they found that in 20% of the cases, there was distal ulnar palsy, whether it was professional cyclist or amateur cyclist, whether it was with gloves or without gloves, and type of handle. So then I told those orthopedic friends, you go into your subject and find out. This is known as cyclist palsy.
Great, sir. So, Dr. Simi can tell us a little about cycling also, because she has done something called as an Ironman. So let's hear from her what the Ironman is.
So I would say Ironman is a big beast to conquer.
Great.
I had a lovely journey during this period.
Yeah, no, you tell us what Ironman is. I don't think not many people would be knowing.
So Ironman is, you have to swim for, this is half Ironman I'm talking. You have to swim for 1.9 kilometers in the open water. Then you have to cycle for 90 kilometers. And then 21 kilometers run, which is half marathon.
All these things are done one after the other.
So the cutoff for a female runner is 9.5, and for males it is 9. So I came second. I got the podium in that, and I finished in 8 hours 50 minutes. This I recently did in Pune.
Yeah, this was recently in Pune.
Yeah.
Oh, wow. Yeah. And how was the experience of swimming in the open water?
So normally the organizing committee they allow you to go in the water a day before. So they arrange a practice session. So it was arranged for us, and then when I went there for the first time, I saw like the water was very dirty. It was not the same as we do in swimming pool.
Yes, totally.
And very slopey water, waves and all. So I was hesitant to enter first. But as soon as I entered, I started swimming, and then it went off very well.
Yeah. So you must have had a lot of sessions before that.
Yeah, we do little
open water swimming.
I did a triathlon before, like 2 years back. I did a triathlon in Pune, in Kolhapur.
Okay. But in the sea, have you swum in the sea?
No, not in the sea. It's in the lake. Yeah, lake and.
Okay. Any memorable race story or experience that you could recount for us?
So this triathlon was the best for me, because after, like once you finish your swim, you have to, there's a transition period, like it is included, like they count that period also. So you have to be very fast in changing. We don't change, the dress is same. It's known as the tri-suit. So we immediately dry ourselves and we pick up our cycles and we start cycling. We come back and then immediately keep the cycle back on the racks and then start running again.
Fantastic. Dr. Nandi, how did you think of teaching classical music? What is it that you enjoy most about teaching?
You see, I like teaching right from the beginning. It's like Professor Shekande used to say, कि माझ्या रक्तामध्येच मास्तर आहे. Similarly, teaching is in my blood as well. And just like teaching surgery, I love teaching music. Basically, I like teaching whatever I know. As Ramdas Swami said, जे आपणासी ठावे ते इतरांशी शिकवावे, शहाणे करून सोडावे सकळ जन. So, this is my passion. Now, I had not started teaching till 2010. In 2010, my Guruji expired. Panditji passed away. And I was thinking what I could do to keep his memory alive or as a tribute to his memory. And therefore, I started teaching 2-3 people. There were some youngsters. One very senior gynecologist also used to come, 75-year-old. And during COVID times, it was impossible for them to come. So now I teach them online.
Yes.
And because of my surgical circuit, it is impossible to teach every day.
Right.
So we take a class on Sunday evenings. Like today at 5:30, there will be a class online.
So are you choosy about the students that you teach?
No. The only thing that is important is the interest of the person. Because I feel any person with any kind of voice can learn music. Because if even you can learn, Sharon. Really you can learn. Because there are many excellent top class musicians like say Mallikarjun Mansur who has a very hoarse voice. But still people throng to hear his concert. Because it is the mind behind the voice that people want to listen to. So anybody can learn. Only thing is there must be passion to learn. It is not a very casual thing because it's a serious art and he should be able to continue it for a long time with patience and perseverance.
What are the nuances of classical singing that you bring to the table as a teacher?
You see, in classical music, the first thing that you must be able to do is to identify 12 notes, 12 swar. Sare Gama Padani Sa hai 7 swar hai, and there are 5 Vikrut swar. So the same variations of 5 of these notes, there are 12 notes. The entire music is within these 12 notes. And you may find it easy, but it is very difficult to identify them when somebody is singing, and you take almost a year to year and a half for you to understand and identify those notes. That is the first thing. Second thing is to be able to reproduce those notes in a perfect fashion with the correct frequency. Once this is mastered, then we train the students in the training of the larynx for moving. So for Tanakriya, for making fast variations. Once that is done, there is a systematic way of that. Then we go enter the rag business, because rag is a concept in which the person must be able to understand the notes first, he must be able to understand and identify them, and then he can start developing into the rag part of it.
As a teacher, if you could be a fly on the wall to hear any particular singer do riyaz or practice, who would that person be? Who would you like to hear?
Without a doubt, it would be Pandit Bhimsen Joshi.
Fantastic.
You see, when I read his biography, it was described that when he was learning with his teacher Savai Gandharva, Kungolkar, he would start his riyaz at 6 o'clock in the morning, would continuously sing for till about 12 o'clock, then a lunch break, and from 2 o'clock to 8 o'clock. This he did for 6 years continuously. So I would have loved to witness that exactly how he did it. You see, riyaz and concert music is different. In riyaz, you don't do the thing that you know again and again and again. In riyaz, you do things you do not know. You have not mastered. So that there is a much more learning in listening to big people doing riyaz. And therefore, I would have loved to be a fly on the wall to hear Bhimsenji do riyaz like this.
So how much originality can there be in classical music?
There can be a huge amount of originality because you see, just like Pritam's paintings, there is a frame which is fixed. He has to paint everything in that frame. He has been given certain colors and then he can do whatever he wants with that. Similarly, in classical music, there is a framework. That framework is of tal. So for example, in teen tal, there are 16 beats. You do whatever you want to do in the 16 beats and you have to come back on the first beat. Then in ragas, there are certain notes which are only allowed. So you have been given 5 notes, you have been given a structure. In that, you have the liberty to do whatever you want. And therefore, I love to see or hear the same singer sing the same rag year after year because I can see the development of his mind in presentation of the same rag as years pass by.
Fantastic, sir. You've just given a very different perspective to listening to class.
Correct.
Thank you so much. Dr. Preetham, tell us a little bit about your exhibitions.
I've been conducting exhibitions with the sole purpose that I do painting only for charity. We have one trust called Vasundhara Charitable Trust named after my mother-in-law, and there is a village called Tarapur, which is near Boisar station, 20 kilometers away from that. It's a coastal village, and there is my wife's house is there, which is around more than 100 years old. There we have developed one clinic, OPD. Then my aim was that I will do painting. Painting will be bought by many people. Few are here already present. They will get their tax rebate, plus they will be feeling happy that they are helping in my trust. And my trust gets money for various purposes, right from even starting a borewell in the school. Starting a borewell for the water in the school costs around 40 to 55,000. 4 or 5 paintings can make that much money, and people get their things. And with this money, I got my pathology lab established over there, second-hand sonography machine, and I go every third Sunday to endoscopy over there. So this is the way I've started, and recently I had my third exhibition at Nehru Center and second one over there.
Yeah, so we have a little bit of a glimpse of Dr. Preetham's exhibition, and I have witnessed it, and they're really good, all his paintings. So.
It's all positive, Ashwini. When I am enjoying painting, and as Dr. Nande said, you are cut off from the rest of the world. The positive thinking is that I am finishing the painting. It comes out okay, good, whatever it is. Someone likes it. It's also positive feeling. Someone wants to donate something positive, and something positive work going on. E-learning program for the kids, and organic farming lectures arranged with all this money. So there is nothing negative about it. Everything is positive. And as Geeta says, I remain detached from my work.
So what about now, you are an artist and you have this talent, but do you think that your natural talent needs to be honed by a little bit of structured training?
Exactly, as Dr. Nande said, he was singing well from beginning. Still, like Sachin Tendulkar also used to play well. But there has to be someone, guru, to teach you. So I did during COVID times. It was tough time working for my nursing home, which was on at that time. It was not closed. And come home on Wednesday and Friday between 2 to 4. I joined one basic art foundation course by one Vikrant Shitole, who is an excellent watercolor artist. And for 2 hours, he has taught us what was a curriculum for the first year of a JJ School of Art. For almost 9 months it went on. And definitely that helps. You can create the same thing. It doesn't happen accidentally. If you learn, you can create the things.
So Mendere sir, which of your treks have you found to be the most difficult?
The most difficult I think was in Kailash Parikrama. The Dolma Pass is almost 19,000 feet. I was prepared for high altitude, but towards the end I realized that the rate of my walking was almost 1 step per second or 1 step for 5 seconds or something like that. And then I realized that you see the movies where they show the mountaineering going to the last Everest. They go so slowly. At that level, I was going so slowly, it was quite difficult because of that.
Dr. Siddhi, any advice that you'd like to give a newbie runner?
So, I would say that take up running, but you should be consistent. That is the only thing in running. My coach, who's Mr. Samson Sekhar, he tells us every day the same thing, that you have to run every day or maybe 4 days a week, but be consistent. Come, have your own, whatever mileage he gives us, we complete. And so that is the only thing which I feel. And other than that, you have to take care when you're running on the road. Yeah.
So
Your safety is very important.
consistency and perseverance. Nandi sir, would you rather go into the past and experience the old masters at their craft, or look into the future and see what the next generation will be up to in classical music?
Good question. I would like to do both. Because finally, you see, we are standing today on the shoulders of our old masters. So just like I like to listen to old masters, I also like to listen to the new trends. Because you see, music is not static, it is evolving all the time. Like Mia Tansen never used to sing Khayal Gaiki, he used to sing Drupad and Dhamar. So his way of singing and our way of singing now, 300 years back, is different. Similarly, now newer methods of singing are coming up. And in music itself, there have been many artists like Jitendra Abhisheki, Kishori Amonkar, Kumar Gandharva, who have introduced newer techniques, newer styles, newer thoughts. Similarly, I also go to listen to the concerts by youngsters like Uday Bhavalkar, Omkar Dadarkar. Dadarkar is a grandson of Manik Verma. Then Kaushiki Chakravarti, she is also very good. Daughter of Nikhil Chakravarti, Abhay Chakravarti. And Arman Khan is another very good singer who is a son of Rashid Khan. He is coming up very well. And Ullas Kashakar's son, he also, his first name is Samihan Kashakar. I am just telling this name so that people who are interested can follow them on YouTube. So these are very promising young artists who will be, I am sure, in 10-15 years, very high level of musicians.
So you think that classical music is in good hands right now?
Absolutely.
Great.
I am very positive and optimistic.
Fantastic. Any thing about remixes? What do you think about remixes?
I have no issue with remixes. You know, basically, as long as whatever is presented is musical, lyrical, and pleasing to you, is good music for me. So I love to listen to remixes as well. See, finally, the definition of a rag by our old pandits is Ranjayati iti raga. Whatever entertains is rag or music. So I am okay with remixes.
Dr. Preetham, who would be your ideal muse? Any person in the world who you would want to pose for you when you are painting?
Madhuri Dixit. As my wife's not around, but there's someone who can tell my wife here. So.
Okay, last 5 minutes, Dr. Kamath is glaring at me, but this I can't let go. This is my rapid fire round. So just literally 5 minutes, okay? Just absolutely 5 minutes. Dr. Mendere sir, 2 people who you would want by your side during a tough trek.
One is Khem Thakur, who also taught me skiing because I came to know when he was on one of the journeys. He's very good skier, trekker, mountaineer. Other one probably again, probably Milind Vide.
I'm going to tell madam that you didn't take her in. If you lost,
Who would like to be on? You said in difficulty.
yes.
So we don't want to increase her difficulty.
Okay, if you're lost on a trek, what would you pick? A fully charged phone or a bag full of eatables?
Oh, bag full of eatables because fully charged phone without signal has got no meaning.
Okay. Would you rather be on an airplane next to 2 arguing passengers or a crying infant?
Probably to arguing passengers because somehow I may be able to shut them up. Child I cannot touch.
Okay. When you write your autobiography, what is its name going to be?
It's unlikely that I might write stories. Many of them would be for others, but what I would say no hypocrisy.
Great. Dr. Simi, any celeb you would like to run along with?
So Kipchoge is a runner. He's the international runner.
Okay.
And otherwise, I would say Madhuri Dixit because she gave me the podium.
Yes. Okay. What song pumps you up during your runs?
Or no song because we are strictly like we don't listen, not allowed at all. So,
Cycling in National Park or cycling on Marine Drive? What would you prefer?
Marine
In the
Drive.
rains.
Marine Drive.
Most scenic running route in Mumbai?
Again, Marine Drive.
Okay, autobiography name?
Life is a marathon.
Great, great. Nanda sir, for you, a song you would have liked to give playback for?
The song by Kishore Kumar, Dila Shayar Hai, Gamaz Nagma Hai.
Oh wow.
I would like to sing that.
Is that there on YouTube?
No, I have not sung it, no.
Okay, so you're going to sing it in
I will put it on.
for us? Okay. Your go-to karaoke song?
Ketaki Gulaba Juhi, Champaka Bana Phule.
A song you think should have been sung by a different singer?
I feel the male part of the Kuhu Kuhu Bole Koelia, sung by Muhammad Rafi, could have been better sung by Manna Dey or Bhimsen.
Okay. Your go-to song to lift your spirits when you are low?
My most favorite song in this kind of situation is माझे Jivan Akadi, written by Mangesh Padgavkar, music by Pula Deshpande and sung by Abhisheki.
Thank you. And the name of your autobiography, sir?
I am very doubtful whether I will write an autobiography because autobiography requires a lot of courage and honesty. So if at all I write a book about my life, not essentially autobiography, it will be the healing art of surgery and music.
Great, thank you. Dr.
I
Preetham?
suggest Madhaj Jivan.
Dr. Preetham, Leonardo da Vinci's Mona Lisa or Van Gogh's 12 Starry Night?
Okay, Van Gogh.
Watercolors or oil paints?
I love both.
Which famous artist would you like to get your work reviewed by?
As I told you, my own teacher, Vikrant Chitole, but he's not that famous, but he's still in his world is famous.
If you had to get a portrait of yourself painted, would it be a Picasso or Raja Ravi Verma?
Raja Ravi Verma.
Madhubani or Varli?
Madhuban.
What name of your autobiography?
Rice plate. I think life should be rice plate. There should be everything in that rice plate. Okay.
Thank you so much. Thank you, Dr. Kamal.
One thing, Dr. Ashwini herself is an artist. She has shown me her sketches. So one hidden talent.